Welcome to the Phoenix Prosperity Podcast, where wealth meets legacy. Join your host, Tim Fergestad, as we explore the journeys of Phoenix's finest to success and beyond.
Hello, this is Tim Fergestad. Thank you for joining us. Today's guest is Niloofar Dehghan. She's an orthopedic trauma surgeon and chief of trauma at the Core Institute, as well as an associate professor at the University of Arizona College of Medicine, Phoenix. Welcome to the show, Niloofar.
Thank you for having me, Tim.
All right. How long have you been at the Core Institute?
I've been there for 9 years now.
Okay.
Yeah.
And where were you coming from first?
So I'm Canadian.
Okay.
I did all my training in Canada, and then I basically moved to Phoenix for work.
So you came straight to the Core Institute
I did.
in the US? Okay. And how big was the Core Institute at that time?
I mean we're the largest orthopedic group in the state. I think we have about 100 physicians, and with levels we're about 200, 250. I think we were slightly smaller 9 years ago, so we've definitely grown since then, but I don't know exact numbers.
Okay. Well, there's the kind of the headquarters is sort of central North Phoenix, right? And then there's different ancillary sites or even campuses.
Yeah, we have multiple locations across the valley. So we're in Mesa, Sun City West, Scottsdale, and kind of our headquarters is in Phoenix, as you mentioned.
Okay. So as our listeners may know, certain hospitals have different trauma level designations, and I'm wondering how that impacts your role as the head of trauma at Core, if you have different relationships with different facilities, or please explain to us how that works.
So the trauma designation thing is very interesting. So there's level 1 to level 5, and level 1 is where the highest acuity patients go with a trauma. So if you're in a car accident, you have a pelvis fracture, femur fracture, you have multiple, bony injuries, maybe you have a head injury, that kind of patient would be taken to a level 1 trauma center. So a level 1 trauma center, that's kind of what you see on TV, like on Grey's Anatomy. That's what a level 1 trauma center is. So critically injured patients come, and there's specific requirements that the hospital needs to have. So they need to have surgeons that are there 24/7, general surgeons, trauma surgeons, there's orthopedic coverage, there's neurosurgery coverage, there's vascular coverage. So it's where the sickest patients go and where there's a lot of resources to look after those patients. And then from there, it goes down to level 2, level 3, level 4. So the higher the number goes, the lower acuity patients are. So if you just have an ankle sprain, you don't need to go to a level 1 trauma center. You could just go to a regular hospital that doesn't have 24-hour coverage, let's say for a surgeon, because you're not critically injured and you don't need acute care.
Right.
So that's kind of how the designations work. At the Core Institute, so we're a private practice orthopedic clinic. We're not, we do have our own hospital, which is a Core specialty hospital, but that doesn't have an emergency room. So, it doesn't really apply to us. So I am employed by the Core Institute. I operate at Banner. So I provide services at Banner hospitals that are level 1. So that's where I operate.
Okay. And within the valley here, for example, I don't know if you're in North Valley, Banner Thunderbird, for example, that's a level 1 now, right?
Yes, there's a lot of, so Phoenix is very interesting. Phoenix is one of the only cities in the country that is saturated with level 1 trauma centers. That's much more than the actual population. It's kind of interesting that way. So most cities have maybe 2 or 3 level 1 trauma centers for the population to serve, but Phoenix definitely has a lot more trauma centers.
Why is that? Is that, I can imagine 2 reasons. One, just the geographic sprawly nature of the valley, but mainly I think it's about reimbursements and money.
Yep, it would be the second one. You said it, not me.
Okay, so but you have to, don't you have to justify based off the local demographics the need to get that designation from someone?
You know what? It's very interesting, Tim, and I don't know the exact details of the
Okay.
politics, whatnot. So, um, a hospital can basically, become a level one trauma center, and the ACS, the College of Surgeons, at the American College of Surgeons, can verify you as a level one trauma center.
Hmm.
So the ACS will come to your hospital and say, okay, you've met the requirements
For
and
all the life-threatening things that
right, of all the critical
constitute
things you
level
need to
one. Right.
have, you have enough personnel, you have enough resources, da 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 da, and you've met it. If you haven't met it, they can't take away your designation because that's kind of decided at the local level. Let's say at the state level, the ACS is a national level, so they don't
Right.
verify you and say yes, you've met the criteria, or no, you haven't. These are things you need to work on, but they don't necessarily give out designations. So the actual
Okay.
designation is made at a state level.
Okay.
And again, I'm not sure how that all works out. I'm sure there's certain metrics you need to meet.
And
But
maintain, right, yearly or
right, and
something. Right.
maintain. I mean, we actually published a study on this last year looking at, this over proliferation of trauma centers. That was basically based on my experience from Phoenix because I came from Toronto, which is a population of, I think more than Phoenix, and we have two level one trauma centers. Everybody north of Queen Street would go up to Sunnybrook. Everybody south would go to St. Mike's. That was it. And the issue with having too many, people initially think, oh, the more the better, right? We could just quick skip and a hop, go to the next hospital. But it's not that easy because to be a good level one trauma center, you need to have qualified personnel. You need to have the numbers. So you need to have, the more of these cases you get, you become like a well-oiled machine where everybody
Right.
knows what they're doing, right? If
Because but things happen fast and you have to be really dialed in. It's
right, right.
life-threatening stuff.
I mean, let's it's something like a replant, right? Like if you cut off a finger, you need to go to a hospital, a specialty hospital that deals with that. So it's hard to find people that do that kind of work. The looking after the patient requires specific teaching and training. You need specific nurses to kind of do
Mhm.
that kind of stuff. And studies have shown if, every hospital decides to replant a finger, it just doesn't work. The outcomes are worse. You need to go to a center that's doing a lot of these cases where people know what they're doing. They're a well-oiled machine.
Right.
And that's where, a lot of hospitals become a specialized hospital, let's say a cancer institute or a heart institute, because that's all they do and they get good at it.
Right.
And that's the same with trauma. So if you kind of dilute the care where, people can go to a dozen places, the care gets diluted. You may not have kind of the same caliber of people, perhaps, because they don't get the same repetition. It
Right.
also affects teaching and education, right? At each of these centers, if you're training other people to do this, it really dilutes the quality of the quantity and quality of cases that they see. So it has a lot of downstream effects.
Okay, right. And so with those challenges in mind, right, you try to navigate those waters and with your affiliation with the university too, are you doing a lot of the teaching?
Yeah, I mean, I work with residents and medical students. We have fellows. So yeah, we teach the next generation of orthopedic surgeons. That's what I do. So I do orthopedic trauma, teaching other fellows and residents how to do orthopedic trauma.
Okay. And how much of your time is spent with that? And are you do I'm sure it's maybe a little bit individual dependent on who you're working with, but for the most part, I imagine you do it because you enjoy it.
Yeah, no, I mean, I love teaching, right? I love what I do and I like to show people what I do and, hey, look at this. This is broken. This is how we put it together. This is how you do it. This is where you put this. And so that's kind of what I do on a day-to-day basis, teaching the next generation.
Okay. What are the added challenges of doing that though? I mean, because sometimes it slows you down to have to teach if you're in a trauma
It
environment.
does, exactly. I mean, academic centers are known to have, it takes more time to teach someone how to do it. So you have to, talk out what you're doing, explain what you're doing, show them the steps, have them get involved. So it does slow you down. But I mean, that's how you teach the next generation, right? You have to take the time to do that.
I imagine every generation has their quirks, but one of the challenges might be in that environment is teaching the mental toughness required to be in that environment. Can you speak to
Right.
that a little bit?
Sure. I mean, I don't think I'm that old, but certainly I feel like I'm generations away from the students currently. I mean, it's funny, when I was a resident, my mentors or the surgeons I worked with would always say how we have it so easy. They were on
Hmm.
call every other day with no sleep, literally on 24 hours, 36 hours at a time.
Right.
Um, and things have certainly changed since then.
Sure.
Um, it just work-life balance is a good thing now. So people are more in tune to that. So you just can't have those the same lifestyle and same restrictions that were on residents 40, 30
Sure.
years ago now.
Well,
Different.
right. Well, I guess I'm kind of getting at the fact that yes, you perform better when you're rested, but being in a stressful environment is part of the training, and just in the fellowship or residency period alone doesn't give you the hours and the experience needed if you're only there a fraction of the
Exactly.
time.
Yeah, I mean, and that is a huge issue. So if you're on 24 hours every other day, you see more, you do
Hmm.
more, and hence you get better. You have, the more you do, it's just those practice hours, you get better, you get a lot more experience. When you cut down the hours from 100 hours a week to 80 or even, less, you see
Hmm.
less, you do less. So you don't have the same experience. And that's certainly an issue and challenge. And we talk about that. And certainly when I came out of residency, I was nowhere as good as, um, people were 30 years ago because I wasn't there living in the hospital, which is what they used to do.
Right. Didn't
Um,
get the reps in.
you don't get the reps in. I mean, and that's why, and that's not just orthopedics, that's just medicine in general. But I think you have to find a balance, right? I mean, residents are called residents because back in the day you would live at the hospital. That was your
Right.
residence.
Right.
And
Right.
it's not practical nowadays. But that's why, people talk about increasing the length of time it needs for residency programs,
Okay.
fellowships now. So you do your 5 years of residency, you go on to do a fellowship to kind of subspecialize in something
Mhm.
specific, get more confident and comfortable with that. It gives you an extra year. Some people do more than one fellowship. Some people take time to, practice and hone in their skills before they go and find a real job, their kind of forever job. So it is an issue for sure.
Right. And I think, okay, Dr. Degan, you are in, I mean, so the OR is a stressful place,
Right.
right? And you need to learn how to deal with that, right? And part of that comes with being challenged and being tired and stressed out. And when you don't train under those conditions, right, it gets harder. And I'd say probably the ED, or the emergency department, is amongst the most stressful of the ORs as well, right? So you have to be
Right.
incredibly resilient and tough to be in that environment. Um, is that part of the training? How are the new residents dealing with that?
I mean, trauma is challenging, right? Like you get a patient come in and it's just there's a lot going on. Everyone's trying to keep this patient alive and, everyone's stressed out and
Right.
tired. You're dealing with a critically ill patient. I see where you're going. I think, your point is, are we more resilient now than we were before? Were we
Because we're well rested, or is it more important to be able to handle the stress, I guess?
Yeah,
Yes.
but also, I mean, you don't want to be in an abusive position, right? So
Sure.
medicine, historically, we eat our young. It's not a warm and fuzzy environment. I read a very interesting article. It talks about how when you first start in your residency, you're naive and doughy-eyed and bright-eyed, and you're so excited to look after patients, and they just
Right.
the snot out of you. And basically, after 5 years, you're the person you didn't want to be, who's kind of being short with your juniors and kind of,
Right.
snippy, and that's just what happens, rightly or wrongly. And I talk about it with my own residents. I've noticed it in myself. It's just it's like being in the military, right? I mean, you just toughen up. It's nothing intentional.
Right.
You don't march around or, bark orders just to toughen people up, but it's just the reality of what medicine is and what trauma is.
Right.
But I also think, it can't be an abusive environment where you're throwing things in the operating room and yelling at people. So, and that's certainly, that happened 50 years ago, but it's certainly not now, and it wouldn't be tolerated. But on the same token, like you said, it is very stressful, and sometimes people do or say things under stress. And I think
Right.
when you're in that environment, you kind of realize it's like the circle of trust. So if somebody says something,
Yes.
I kind of know it's in the moment, and I
Right.
might be short with my junior or whatnot, but we all know, once that situation's over, you can kind of decompress and move on. So you know that
Right.
none of that is really personal. But
Right.
it's hard, I think, for an outsider to look in sometimes. They may not necessarily understand it, but it's kind of like you're at war, right? You're at war, you're trying to keep someone alive and all of this. And so
And
whatever
there's
happens,
blood on the ceiling and things are, yeah,
right?
it's
Like
intense.
it, and I think that's sometimes where people get in trouble, or where things get said as an outsider, that they think, oh, this was inappropriate or whatnot.
Right.
When you're in it, you're just trying to save a life.
I really like your term circle of trust. I think that's what it comes down to. That's a great point. Is you have to trust who you're with and know that you're not walking on eggshells. You have to focus on the task at hand, and it's intense. And if when your teammates not on the same page, or they're going to go write you up afterwards, and your job's on the line when you're trying to perform your job, things like that, that creates a whole nother level of complexity that I don't think is in the patient's best interest.
Right. I mean, at the end of the day, and I've been in situations where people are, arguing over what to do next, and, you're just trying to help the patient, and sometimes emotions are running high. But
Right. Right. Okay. Thank you. Thank you for sharing that. That's it's everyday fact, right? I mean, in dealing in the industry, that you have to navigate those waters.
right, yeah. And, it's funny because sometimes, yeah, I think even as a woman, like, people have this notion that you go to the doctor, they hold your hand, and just sometimes we're not like that because we don't want to be. It's just we've been toughened up.
Right.
and
Yeah.
and
Yeah.
the stuff you see every day, it just it changes you.
For sure. How can it not, right? If particularly if you care, right?
Right. Yeah. Um,
So, okay. Wrapping up sort of the challenges of being a trauma surgeon. Uh, What's one of the biggest ones you've had uh, in your role there at Core, for the in sort of a company perspective?
what do you mean?
Well, what are some of the bigger challenges you've had at being the head of trauma at Core?
Um, I mean, we cover multiple hospitals, multiple banner hospitals in terms of providing trauma services. So
Okay,
managing that can be challenging when you have uh, people leaving, or we take on a new hospital and we have to kind of
sure.
uh,
Scheduling aspects.
manage that, schedule it, kind of managing expectations and meeting the demands and providing quality care, that kind of thing. So that's kind of what I
Have,
do.
have you had to do more or less clinic or OR stuff and more bureaucratic management tasks?
Um, yeah, I mean, I do more admin stuff, administrative work, just because of my role. But no, I mean, I still fully, you know, 100% clinical, so 100%
Okay.
time, operating room time. Yeah.
You're not, do you have plans on transitioning into more admin?
Um, Not necessarily, no. Am I gonna quit operating and do administrative work? No, I couldn't do that. I love being in
Okay.
the operating room and fixing people, putting things back together. I do like leadership positions and, being involved, having a say at what happens, but I would never trade one in for the other. So I would kind of keep doing what I'm doing, which is managing both.
Okay. Okay. Are there goals for the next year or two for the core or the trauma, trying to grow it and get grow the team?
Yeah, I mean, we've talked about that in terms of potentially covering trauma at other sites, and that's we're looking at that and seeing what the future brings.
Okay. But are you sort of involved in that, or do you just run the department and just keep your head down and run the trauma section, or are you actively, like, I don't know if Tchaikovsky's involved or some of the other the head people, are how active they are in recruiting people and trying to get other contracts and grow it?
Yes and no. I mean, I'm involved on the practical aspect of running trauma, but also I'm involved with the overall um, you know, mission of the organization. So if they decide that we do want to do more trauma or that kind of thing, I would definitely be involved in that. And we have spoken about it before, kind of expanding, but I mean, I'm not a business person, expansion, you want to make sure you don't expand too quickly. Otherwise, that's not a good thing either. And you want to make sure
Right.
you have resources to provide the care you need. So it's kind of a complex thing. But I
Okay.
mean, we're still we're large, but it's not that large. I mean, everyone's kind of close by, so we do communicate back and forth.
Okay. Okay. Right. Well, you're wearing a lot of hats. I'm very impressed. It's sounds like a lot of challenges every day in the in the ED too. So, uh, you must be pretty resilient.
I try to be, yes, I do try to be.
All right. So it sounds like things are going really well for you. Looking towards the future, I have like a third of my investors, for example, are business owners. A third of them are medical professionals and stuff. And one of the conversations we have is talking about the future and maybe how they may at some point they're going to retire, or at least start dialing back their time and stuff, and maybe replace their income with active or passive income and stuff. Can you share your thoughts on some of that?
Um, well, I can tell you I have absolutely no business sense and I don't know anything about investments. And so, yeah, I would be the worst person to talk about business and investments and retirement planning. I basically put my head down, go to work. Somebody puts money in my bank account every other week. And that's kind of,
That's a very common theme, though. A lot of
yeah,
people, a lot of
I
physicians are that
stick to what
way.
I'm good at. And that's, fixing broken bones.
Sure, which is
Um,
which is probably the best return on your time, right? Right now is that's what
Actually
you
not, but I think you can definitely get a better return doing something else, but it is what it is.
okay. Well, yeah, again, that's not an uncommon feeling amongst physicians right now either, right? Because you work so hard and it feels like reimbursements are down and so on and so forth.
Yeah, I mean, it's interesting. Everyone talks about when their annual raise doesn't meet inflation or,
Right.
whatever group goes on strike because the annual raise they're getting is suboptimal, not as much as they were looking for. I mean, Air Canada, the flight attendants for Air Canada were on strike, which went on for quite a long time, and they got a huge raise out of that. As doctors, we're the only profession where instead of going up and maybe
You've
not
had pay cuts.
inflation,
Yes.
we actually go down. So um, I don't know of any other, job where, annually you're going to get less and less. Meanwhile,
Yes.
everything
It's
else goes more, the costs are going up. So yeah, uh, I would say you definitely don't become a doctor for the money. Or you
uh,
shouldn't. You can certainly go into business or other things and make much, uh, probably more money for less stress. Although I don't know, that's just, I'm sure business is also, obviously it's very stressful, but kind of a different type of stress.
Sure, sure. And to your point, you also most, I think, I don't remember what the average numbers are right now, but the financial debt you have when you even start your career, once you're finally done with your training from all the medical tuition, student loans and things like that, on average, is hundreds of thousands of dollars in debt, and you're starting way later than everybody else. So
Right.
it's financially challenging to be sure.
It is, and that's one of the things that kind of irritates me when people think, oh, as a doctor, you're money loving,
Oh,
greedy
yeah.
person who went into medicine. I mean, I didn't start practice until I was in my late 30s,
Yep.
compared to, let's say, my friends who got a university degree started work when they were 23, right? So I'm 15
Yep.
years behind. And on top of it, if you
And
look at
hundreds of thousand dollars in debt.
right. I mean, I was lucky because I did my training in Canada and it's not as, expensive as here,
Okay.
but in the American system, once you're done, like these kids are graduating with $400,000 debt. I met a girl last month who did engineering and then decided to go into medicine. So she said she was $750,000 in debt. So she needed to get a job to pay back that 750 before
Right.
she can even think about buying a house or,
Right.
saving or anything. So, and people don't, I don't think most people realize that or think about that.
Right. All the sacrifices that people make in the medical field just to try to help people, and they're often attacked for, right. Yeah, you're right, not being compassionate, because like you said, there is burnout and other stuff. You have to get from one room to the next, and you don't have the time, and they think you're uncaring and all that, and it's unfortunate.
Yeah, I mean, physician burnout is a huge issue right now. I, it-
Yes.
I mean, back in the day, right, maybe in the 50s, 60s, 70s, doctors were looked at differently than they were now, right? You looked up to a doctor
Right.
as a kid. They were, maybe someone you wanted to grow up and be like, and they were almost put on a pedestal in a way. Now
Yeah.
it's just sometimes it's like you're the same as a Starbucks barista, right? You go to a doctor, you demand to be seen right away within your 5 minutes of your appointment time, and it's not the same, and just the demands on doctors are a lot higher just from insurance companies, which obviously that's a whole other topic, but they really do make the system much more harder to navigate. We have to fight for our patients to even provide care. I have to call insurance companies and explain why this patient needs an operation to have their shoulder function, which they're refusing to pay for. And, you're kind of stuck in the middle trying to
Right.
fight for your patient. So there's a lot of things now we deal with that didn't happen back then. And, I had a patient a couple of weeks ago who came in who I was, in my clinic that I was late seeing because I was stuck with the patient before who had a lot of issues and we needed to
Hmm.
sort through. So hence I'm late to the next appointment. And this lady was just so rude and basically made me feel like absolute crap. So I operated on her, got her fixed up. She's walking around and she said, thanks for nothing. I hope I never have to see you again. That's what I'm getting.
Wow.
I've already fixed and helped so she can get back on her feet. And that's the stuff we deal with day and
Wow.
night.
That's
Um, and it's interesting because if that same lady had her internet signal go out and the internet company would say, okay, we'll be there between 10 and 2, sit at home and wait for 6 hours for one of our people to show up. And you would happily wait for that person, right? You wouldn't yell at the the technician when they finally show up. Yeah.
she might, but yeah.
Yeah. Um,
But
and
that's the opposite of it's not just that they're like not as grateful as they could be, but they're ungrateful. They're angry at you. That's
well,
crazy.
yeah, I think society in general is just angry lately, right? Like
Sure.
everyone's just, where's the niceness?
On edge.
Maybe I'm in the wrong decade. Like, where's the 1950s when everybody had a nice little
Right?
house with a white picket fence and people were happy?
Well,
Yeah.
Dr. Dehghan,
What part?
you're a hero, and we very much appreciate you. That's
Why, thank you.
you.
Thanks.
Yeah, it's hard. Yeah, it's. I get my wife says similar things from time to time, right? She'll come home every now and then. She'll have. It's often the elderly population, right? Those patients are the most grateful. and the younger ones are just annoyed and they don't care that the problem is their fault or that they did it to themselves, and they're continuing to do it to themselves, but
Right.
they just want you to fix it and to not be so annoying.
Yeah. So I mean, I have lovely patients. So many of them are
Excellent.
great. I love, I love operating on people, whether they are or aren't. But I think just people in general are angrier lately. Um, everyone's more stressed out. Just society's
Yeah,
more stressed out and on
on
edge.
edge.
So
Yes,
yeah,
for
we
sure,
all
for
need to be
sure.
nicer to each other.
We do. Yes. Um, okay, here's a question I've started to ask you I really like is what have you done in the last 12 months that has changed your life?
Um, that's interesting. I'd say probably social media.
Huh.
Um, so I mean, I didn't really do any social media on a professional level up until
Okay.
last year's when I started,
Hmm.
and that's definitely changed things for me in terms of people know me now. I go to national, international meetings. People
Ah,
have seen my work. I mean, it's funny because you write books, you publish articles, present at various meetings, but unless you're on Instagram or LinkedIn, where you have, hundreds of thousands of people see you,
right.
it's sometimes difficult.
Okay. Yeah, I mean, I used to be in that space. I mean, we would write publish research articles, and you're a text name on a paper with other people, and you go to a conference and you kind of put things together. But we're visual creatures, right? And so when people see you up on the screen, they're like, oh yeah, I know you. You're
Well, and
famous.
nobody reads books anymore. I mean, back in my day, we had actual textbooks. I make fun of my residents
Right.
for like, this is a textbook. We used to read this to learn about
Yeah.
orthopedics. Now everything's online, right? Access is
Right.
so much easier. So you don't necessarily, see the authors of the printed material.
Right. And the different media and the tangible physical objects help us remember it better too, which people are starting to figure out, right? And the actual writing and taking notes is super important too versus
Yeah. And I
typing and
think,
things.
just reaching a larger audience. So I do a lot of teaching education, like I said, nationally, internationally at meetings, but especially reaching people across the world. So it's obviously much easier to do that online, where there's so many, obviously so many people around the world that would benefit from it. So that's been.
Right. Yes, for sure, for sure. Just circling back to that, I wanted to ask you, I forgot, was what sort of maybe projects or research studies are you working on, and with what frequency are you able to do that in your position nowadays?
I mean, we have multiple studies going on at a time. So I work with my residents, medical students, that kind of thing. My passion's always been clinical trials, so randomized clinical trials where we, have a specific question: would this injury benefit from, let's say, surgery or no? And you randomize
Okay.
patients, half get surgery, half don't. You follow them for a year or two, see which outcome is better. And that's what you really need to change practice.
Right.
Um,
Evidence-based medicine.
Evidence-based medicine, yes. So it's much easier to do that type of thing at an academic institution, I would say, than private practice. So that's been a challenge, but
Right.
we are doing some randomized trials now, even at core. My main focus is orthopedic trauma, so broken bones, and how do we improve outcomes? So is this surgery better than the other surgery, or should we rehab patients sooner, or should we, this technique versus that technique, that kind of thing?
Right. Always trying to improve things.
Yeah.
Excellent. Excellent. Okay. Okay. Reflection question now. What do you wish you would have known sooner about building wealth and success earlier in your career?
Well, I already told you I don't know anything about building wealth, so
So maybe a little more, they should throw in a class of that in school at some point.
Yeah, no, they should. My husband has a joke. It's, what do you call, I would probably actually can't even say the joke properly, but it's something about doctors not knowing how to manage wealth, and they're just basically throwing money in the fire pit. Yeah, that would definitely be nice in an in any medical field because, we're so good at one thing or we focus on
Right.
one thing and we really don't know how to manage things.
Right. We
Once
were
you
the same
pay off
way. Yeah.
loans and once you pay
Yep.
off loans and you actually have some money to do something with. But in terms of success, I would say just believing in yourself and being confident in yourself. So I find in medicine, and it might be just a woman in medicine type of thing, but once you're going through, there's always people ahead of you because you're in this hierarchy.
Mhm.
And when you're done your training and you're finally out, at least for me, I never felt like I'm done because there's still, so many people ahead of you. So you always feel like
Right.
you're a constant student for life, right? Like you're always learning,
Yep.
techniques are changing, but to trust yourself and what you're doing and believe in yourself. I think I wish I had that sooner or earlier in my career.
Okay. Well, medicine is a practice, and you do get confidence through practice, right? Through getting the reps in and all that. So, and I think the fact that some of the best surgeons I know are driven because they're always seeking improvement, right?
Right.
Because maybe, I mean, they're not. There's some ego and arrogance you get, because you can come in and change people's lives and save them and stuff. So that you can't not be proud of that. But some of the best ones are the ones who are always striving and pushing themselves and want to improve and aren't happy with where they're at right now, which is kind of a funny balance to have to keep.
Yeah, I mean, that's why we're stereotyped as a bunch of type A personalities who are driven and focused, and we're not the easy, happy-go-lucky types of people, right? We're very
Right.
goal-oriented and hard on ourselves for a reason.
Right. Right.
Yeah.
Good and bad.
Yeah,
Mhm.
yeah.
Okay.
I
Excellent.
did read a
All right.
study that women outlive men in all aspects, except in medicine. So women in medicine actually die earlier than the men in medicine, and it might be because of that. We're just too hard on ourselves, and
Wow.
yeah.
That's a dark stat. I didn't know that one.
I know. I just read it a few weeks ago. It was actually depressing. So, but
Well,
yeah,
now that you know, you can do something about it.
I know. Maybe I can quit and go have a margarita on the beach somewhere and just live longer.
Um, well, that'll be an N of one for that study. We'll see.
Sounds good. Maybe I'll go on the beach with your wife. We can go have a margarita.
That sounds lovely. I think you should do that. All right. All right. Well, Dr. Niloofar Dehghan, if people would like to connect with you or learn more, what can they do? Where should they go?
The Core Institute.
Okay.
You can look me up on the Core Institute.
Site. Okay.
On the Core Institute website. If happy to see patients with any kind of fractures or orthopedic trauma, broken bones, that kind of thing.
Okay.
And yeah, my email address is niloofar.dehghan@thecoreinstitute.com.
All right. Excellent. Well, thank you everyone for listening and watching. Thank you very much, Dr. Dehghan, for joining me today. Very much appreciate you sharing your insights into the industry and the challenges of modern medicine. Thank you.
Thank you, Tim, for having me. I appreciate you.
Inspired by our guests? Visit phoenixprosperitypodcast.com/guest and join us on the show and share your success story with Tim. The spotlight awaits.